Welcome everybody. Thank you for coming to Research Innovation Conference this week. It's great to see you all in person, and we have a really great lineup today. We're going to get started with Dr. Christine Jones, who I'm just meeting for the first time. I'm very happy to meet. Christine is an internist, and her well-funded research through NIH and the VA is actually focused on implementation and evaluation of transition of care, both in veteran situations and palliative care for non-veterans, both in Colorado and nationwide. It's really important work, and it leverages off a talk by Amy about a month ago. So we've got some nice continuity here of themes. And today, Dr. Jones is going to talk to us about leveraging innovative mixed methods in the VA Transition Nurse Program. Thanks, Christine.
Thank you so much. Thank you so much for that introduction. It's great to be here with you all in person. So yes, I'm currently serving as interim associate director for the Center of Innovation that we have at VA, which is a really wonderful group of people. And I wanted to take a chance to kind of feature some of the work that we've done over the years. So it's about 80 investigators and staff, and we work on national programs that are research, quality improvement, and program evaluation. And my role is the interim director right now. I also co-direct Advanced Health Services Research Fellowship for postdoc PhDs and MDs who are interested in health services research. So if anyone is really interested in learning more about that, please reach out to me because we are actively in recruitment season. We'd love to have some great candidates to work with. So the goals for today are to describe this Transitions Nurse Program for rural veterans, share how unique VA funding opportunities can encourage innovative methods, highlight how we've used some of these methods, we've developed, tested, and refined them during TNP, and then share some lessons that we've learned along the way with this program. So what is the Rural Transitions Nurse Program? So at the Rocky Mountain VA Regional Medical Center, where I work clinically as a hospitalist, we take care of veterans from all over the area. For example, Montana, South Dakota, Wyoming, then around the Denver area, but then maybe in the mountains outside of Pueblo. So we have a really large catchment area, and we have a number of rural veterans, and they really have unique needs as they leave our urban medical center where they had to come for an acute care hospitalization and then transition back to their rural community and their primary care provider. So way back in, I believe it was 2014, Bob Burke, who's also a hospitalist and an investigator, he came up with this idea that, we really need to think about how we can best support veterans who are transitioning back to rural communities, and came up with this idea for a transitions nurse. And their role was to do a discharge readiness assessment while the veteran was still in the hospital, where they could identify the need for things like follow-up care or even transportation medication needs, and then coordinate care actively with primary care providers across settings. So making sure that that rural provider knows that their patient is in the hospital, and then making sure that they have follow-up with them after they go back to the rural community and that they have the records that they need. And then doing a post-discharge call with the veteran. So back now, almost 9 years ago, that was pretty innovative for transitions of care. A lot of these concepts and a lot of these practices have now been kind of integrated into care transitions as best practices. But back at the time, we weren't doing it very frequently. So he did a pilot study with, and one of the key players in this was Lynette Kelly, and she is a research nurse who at the time was working in the clinical setting, and she served as a transitions nurse. And they piloted this in 303 veterans from 2014 to 2016. And there were almost 6 total contacts with the veterans who were enrolled, and 21.8 minutes spent on average in the pre-discharge readiness assessment and preparation, and then 12 minutes for the follow-up phone call and any additional follow-up needed after that. And what they found was that they significantly increased 14-day primary care follow-up, which in the VA is important. We really want our people to stay within VA and come back to us. And then a trend toward fewer unplanned 30-day readmissions. And here in the upper right-hand corner is the difference in differences analysis that they did, where the intervention had an effect on primary care visits within 14 days, so that up to over 80% of the enrolled veterans had that follow-up, whereas in Salt Lake City, which is the light gray line, this trended downward. So they did a comparison in that way. So based on that, they proposed expanding this and doing a national implementation study, and the Office of Rural Health funded about $5 million to implement TNP at 12 sites over 4 years. Now, a lot of this funding actually went to support a full 1.0 FTE of a nurse at the VA medical centers where this was being implemented, and then 0.15 of a physician site champion. And then in 2020 to 2021, Dr. Leonard and I proposed to have one additional year of about $250K funding for 3 additional sites where we went down on the FTE provided for nurses. So I just wanted to take a minute to talk about some of these unique funding opportunities, right? We all know about the traditional research pathway. And I would say that in VA, the grant application and review process is similar and comparable to NIH. And we have kind of these health services, rehabilitation, and clinical research kind of silos where people submit their research grants and are funded. There's actually a realignment in process, so that may not be the case this time next year. But there's also quality improvement, and there are these quality enhancement research initiatives where you can conduct programs as quality improvement. And so you're not doing consent, you're doing quality improvement, but these can be up to $1 million a year to do evidence-based practice implementation across up to one of the ones that I'm a part of is 18 different sites is what we've proposed across the nation. But then there's operations projects, and there are program offices within VA that fund projects that are aligned with their mission. The Office of Rural Health is one example of this. So they have a lot of money to potentially support initiatives that can improve care for rural veterans. And this is who funded this. And these are more like business proposals. Maybe they're 5 to 8 page business proposals that you turn in to show how you're aligned with their mission, their role, and funding and evaluation plan. And these are also typically conducted as program evaluation, not research, or QI. So there are kind of these unique opportunities, but ours was the bottom one. So how did we think about leveraging mixed methods in TNP? And again, a lot of these projects are actually ones that were led by this enormous and very talented team. I came in later to the project, 2019 to onwards. So they were very thoughtful about how they combined the strength of quantitative data with the strength of qualitative data, so breadth with depth, to study both the implementation and effectiveness. And I would say that a lot of what was performed during this program was multi-phase. So we may have done a couple different qualitative types of analyses, combined them, and then gone into a quantitative phase and then back into a qualitative phase as we were kind of doing multi-phase implementation, as well as convergent parallel, where we take the quantitative, qualitative, and you merge them and interpret results. So this was designed as a hybrid type 2 study where the primary aim, there were co-primary aims to both determine the effectiveness of this clinical program and also to determine the feasibility and potential impact of the implementation strategies. So what they did to try to give some structure and also some thought to the context around the implementation was to use the PRISM model, which our friend Russ Glasgow was part of creating way back when, but we found this to be a very effective tool to think about the pre-implementation phase as well as implementation and maintenance. So here are some examples. I put in links into this talk just in case people wanted to learn more about each of these, but these are the 5 studies that I'm going to briefly highlight about how we used qualitative methods, quantitative methods, and what we learned as we went along the way. So the qualitative methods and the projects that I'm going to feature today really were during the pre-implementation stage, as we were going out to those 5 initial VA medical centers who wanted to implement TNP. And I kind of combined PRISM with the way that the team thought about how they wanted to operationalize this. So as they were looking at PRISM for pre-implementation, they were thinking about the intervention and the organizational perspectives and completing key informant interviews, brainwriting, veteran interviews. And then there were also thoughts about how does this affect the recipients? And they did some opportunistic observations of hospital and primary care teams as they were discharging veterans back to the rural communities. And they kind of combined all of these to really understand what the landscape was like for implementation. And you're probably wondering what brainwriting is. I'll get to that in a slide or two. But what they found from this work, where they took all of these different types of data and combined them, were that there were a lot of opportunities to improve care transitions with TNP implementation, but there were also some potential pitfalls that they needed to think about avoiding. And I bring up these two quotes, or these two different bits of data, because they identified that there were potentially some areas that TNP could help with, and also some potentially areas for redundancy. So the first is, a lot of times what we have happen at discharge is they're not given the supplies they need. So we do our 2-day call from the primary care perspective, and the patients are like, I don't have this. I don't have my oxygen supplies. I need this. I need this. And those are things that could have been initiated from the inpatient side. But then in the brainwriting, this is a written submission. They say, I think this role of the transitions nurse is awesome and much needed, but we have PACT, which is primary care managers. And this is some of what they're supposed to be doing, which is the follow-up phone call. So they're like, so what's that all about? And so we're trying to figure out, how do the transitions nurse make calls while the primary care nurses are making calls without having there be a lot of kind of redundancy.
Question. So is the program available, or it's all discharges, or does it particularly focus on high risk patients with certain types of characteristics of discharge? Or?
Yeah, great question. So the question is this available for all types of patients, or just those who are high risk? This is really targeted to people who are going back to rural communities, but then also some of the individual sites targeted specific populations. For example, one of the VAs wanted to do something about their post-hip replacements. So, and that's not traditionally thought of as a population that's at really high risk for readmissions. But I think that they had noted that there were potential gaps that they wanted to address in those patients. The other thing that we leveraged was the CAN score, which is similar to the LACE score. It's one of these kind of, risk assessment scores to see if they're at high risk of mortality. And so that's what the VA uses, is the CAN score. And so people with really high CAN scores are also, people that we really tried to pick out for this intervention. So what is brainwriting? So this is getting into some of the work that Heather Gilmartin and the team led. So this is a written silent group brainstorming activity, and group members are asked to identify reasons that a program, in this case TNP, might fail, and write them down, and then the group discusses their thoughts. And I think this is a really interesting approach because it mitigates some of what we run into with qualitative research, which is that there's this extrovert bias, right? So the voice that's the loudest is also the voice that's the most extroverted. And this way, everyone contributes in the written form so that they contribute to the data, even if they don't feel comfortable speaking up a lot. And so what did this look like for TNP? Well, they went to these 5 different sites that were going to implement, and they tried to get some groups from the hospital, some groups from the primary care clinic, in groups of 4 to 10, and they would meet in person, and the facilitator would talk about the program and tell them what it's all about. And these are people who would actively be touched by the program or implement it. And they would have to think about challenges they've experienced when they've tried to implement or participate in similar programs. They were given a pen, a piece of paper, and they would write their thoughts. And then they would place them in the center of the table, and then they would take a different piece of paper, read what was written, and maybe add new ideas or expand on that idea before turning it to the center of the table. You repeat this for about 10 minutes, and then the facilitator collects all of the written pieces of paper, and then they have a discussion that's recorded. So all of that data was analyzed from 5 hospitals and 5 clinics. And there were 116 total participants with 217 unique ideas related to potential barriers. But multiple sites also generated how would they think about mitigating some of those barriers. So this is kind of one of the supplemental tables from that publication. But if there were, for example, primary care clinic context, that there are no appointments available, well, they would try to come up with some of the ideas to address some of these barriers. Do they need to hire more? Do they need to open more flex spots so that people can have them for follow-up care? The final paper that I'm going to feature in the qualitative part of this are process maps to guide implementation. I think a lot of us are familiar with the concept of process maps. I feel like I've seen it as a hospitalist used as a way to think about what could we really, where is there, time waste? Where are there lags so that we can, make things more efficient and potentially cut down length of stay, for example. In this case, they took data from 42 key informant interviews, 41 observations, and 14 focus groups to think about what is currently happening for these veterans and how can the transitions nurse work in a synergistic way so that it enhances that experience for veterans without being duplicative, because there was a lot of kind of potential siloed activity going on, but bringing all of those kind of steps together and figuring out how to work with them was really important. So overall, I think what I've carried forward from this is that qualitative methods for pre-implementation work is useful and incredibly informative as you're preparing to implement new programs. And we have carried a lot of these methods that I've highlighted forward into other projects and processes. I've incorporated PRISM as a framework to better understand context for implementation to almost all of the studies I'm working on right now, and to construct interview guides for qualitative studies. It can really help you understand the different things that are influencing a hospital ecosystem, for example, as you're trying to discharge. And then we've actually started using the pre-mortem at the beginning of projects in the COIN. Dr. Ho can also, that this is something that we do when people are getting started on new projects, that you meet with the people who are managing your personnel to figure out why might you fail and try to problem solve early before you even get started. And then the use of process maps to identify key individuals in a process. I just got off a call before this talk where we were talking about how we need to process map out how home health referrals actually work at VAs, so that when we're trying to understand some of the gaps in the process, that we're talking to the right individuals. So this is something that's been really useful. Any questions before I move on to quantitative methods? So here's how we've used some quantitative methods to assess implementation and effectiveness. As we have thought about evaluating this program, we've used the re-aim part of the PRISM framework. And we found that GIS mapping is really helpful to understand the reach of a program, particularly as you're thinking about how well are we doing with reaching rural veterans. So on the left-hand side of this slide is actually Iowa City, and you can see how diffuse the X's are. So each of those is a veteran that we enrolled in the program. In Florida, you can see there are some pockets where people might be in, outlying urban centers, but they do go all the way kind of on the Gulf Coast and then up the Atlantic coast too. So this was a really useful tool to communicate with the sites about, if they're wondering, how are we doing? How are we reaching veterans? You just put this in front of them and there it is. So this was a really, I think, interesting use of GIS mapping, which is a skill set that our team had. And finally, this was our penultimate paper, was the effectiveness of the Transitions Nurse Program, which included the over 3,000 veterans who were enrolled from April 2017 to September 2019 at 11 sites. We compared this to them to over 6,000 propensity score matched controls, and tried to understand how did this affect primary care visit follow-up within 14 days. We found that it did increase or compared to the propensity matched controls, which were within site matched. So TNP had about 54% of them had primary care visit within 14 days versus 34.4% of controls. Readmissions and ED visits were not different between the two, but death within 30 days was markedly different, to the point that we did all kinds of post hoc analyses trying to understand what our unmeasured bias was, because it was so different. So the hazard ratio is 0.33 for those who are enrolled in TNP versus controls. And this is the Kaplan-Meier curve on the right.
That's accounting for baseline risk factors and morbidity.
Yes. Mm-hmm. Yeah, it's interesting. So I guess one of the lessons learned from that is that it's harder and harder to get propensity score matched controls published. And that we need to think in some ways with quality improvement initiatives and program evaluation initiatives about how we can mitigate some of that potential unmeasured bias. So one thing that we carried forward that we started doing in one of the query projects is that we've been implementing TNP, but it's for patients going home with home health. And we might have 0.25 of a nurse, and they can only get to one of the 5 patients that are potentially eligible. So they flip a coin and they select the person that way. So you can have some randomization in some ways when you have a list of people, but you know that you don't have the resources to get to all of them, that you can randomly select one of them from that group and potentially hopefully mitigate some of that bias. And then the other 4 are controls. So here's just a listing of the additional studies that this team has produced over the years. So we have a sustainment paper, a healthcare utilization cost that was an economic analysis, relational coordination surveys across 11 sites, which Heather Gilmartin has led. And then effective dashboard audit and feedback, an adaptations paper, which has already been highly cited, which was led by Michaela McCarthy and Lexis Demota, and the protocol paper. So just some closing considerations that if I were to be part of the team from the very beginning and know what we know now, what would we do differently? I think that what was done really well was that, we needed expertise from multiple people that have qualitative, quantitative, and mixed methods, economic, D&I expertise, and the funding to match. So we had quite a good funding stream from ORH. So this, I think, was done pretty well. And we had a very large team over the year. Over 32 investigators and staff contributed to over 12 publications, and I know I'm missing some, so my apologies to anyone who's listening from the team that I missed any publications, but this is a word cloud of all of the different authors that contributed to this. So you can see who really drove a lot of this work: Chelsea Leonard, Heather Gilmartin, Lynette Kelly, and then all of the other people who were involved here on the word cloud. So, and then Robert Burke, who initially started this. So some of the challenges we ran into was that it can be challenging to determine how best to combine or not some of these products. And I think the team did a really good job of thinking about different angles, right? So using the PRISM versus thinking about brainwriting versus thinking about process maps. These are all innovative and interesting angles on how to use these methods. But then the timing can be tricky when you're also considering the timing of the funding. So one example is that our outcomes paper and our econ paper went in at the same time. It took us a little bit longer to find a home for the outcomes paper because of the concerns about the propensity score matching. And so the econ paper was ready we had to ask for a couple of delays on submitting the revisions, because what we were worried about is that we were going to have to change the whole cohort in the outcomes paper, and we wanted the cohorts to be the same in the outcomes and the econ paper. So juggling that was kind of tricky so that we were consistent. And then the funding timeline. So the ORH funding finished in September of 2021, but sometimes it's challenging to find the bandwidth when you finally have all the data and you want to publish it, everyone suddenly doesn't have funding to do it, which I'm sure a lot of you in the room have run into. And then branding, looking back, it would be, if you have a memorable name for a project or a program, to use that in every single title of every single article is really important, so that you have a body of work that is searchable and recognizable. We didn't start doing that really until the last 2 to 3 years, but that's something that I've learned that I should do going forward. So that is all that I have. We've learned a lot more lessons, but that's all I have for 25 minutes.
Have additional question? Yep. Online says, can you say a little about how you determined that something was a unique construct or part of another construct from the brain rating?
Ooh, that is a question I wish Heather Gilmartin were online for, since she led a lot of that work. So I think, they took a content analysis kind of approach to looking through the brainwriting written content. But I'll be honest, I would need to field that to Heather. So if they want to reach out to me, I can connect them with Heather and send them the paper. I'm happy to do that. Great question. Dr. Yu?
What have patients reported about the TNP? Like how they have experienced it, like what did they enjoy or not enjoy? I'm curious about
Yeah, so we did do a whole IVR analysis where the veterans enrolled in TMP would get, calls and asked about their experience and had really high ratings of the satisfaction. There are a couple of quotes about, this is the first time someone's pulled everything together for me. So I would say it was really highly, they were very highly satisfied and it was very acceptable for them.
Can I ask you, you've spoken about trying to pass out the qualitative versus the quantitative for papers and how to arrange those. How did you mesh those content experts to get a continuous product that made sense across all sectors?
Yeah, it was really an interesting, like we would have team meetings all together with the qualitative and the quantitative folks, and Borska Rabin would call in as our D&I expert. And I think that there would be people who would step up to lead specific qualitative projects, but the quantitative people would also kind of know what was going on and contribute to that as they were able. But I think we really tried to be as inclusive as possible and give everyone a chance to shine. So there was a lot of that. You'll see that there's not one person who led every single one of these papers. So I think that was the other thing that we did well, was trying to give people a chance to lead something that they felt passionate about, and for everyone to contribute if they felt that they wanted to, but also going through, the ICME authorship criteria guidelines. But we were pretty strategic about this, and I give Heather Gilmartin a lot. She and I co-directed for a while, and she was the director. So we've had a number of different directors, but she was very strategic about how she thought about how does this inform that, and how do we try this thing to affect this thing so we get this downstream outcome. It was a lot of weekly meeting discussions around this.
So thanks, Christine, that was great. So how do you think about control groups, right? I think the challenge with a lot of these clinical programs is you roll them out, but then when you want to go back and publish,
right,
you have to think about, is it just, are results real, right?
Right, and that's something we ran into with the outcomes paper. See, I was describing that with the query project that we're doing right now. So now we have a different funding mechanism, so we can't support a full FTE of a nurse. So there might just be 0.25 supported by the VA Medical Center. So they have a whole nother job. So maybe there are 5 people that are qualified that could enroll in TNP and that are getting home health services, but they can only get to one of them that week because they have so much other stuff that they have to do. We have them either do random.org and put in a number of 1 to 5, and whichever one comes up is the patient that they enroll. Or we have them flip a coin, if there are just 2 people. So that's a way that we've tried to, and I work with Gary Grunwald on this, how do we introduce a random kind of element without not being QI? But I talked to all of the kind of powers that be at VA, and that's something that we can do.
That's interesting.
Thank you.
Thank you.